Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from April the 17th to the 24th. Here's the overview. On April the 20th, the Heart Rhythm Society released a scientific statement on artificial intelligence integration framework into clinical electrophysiology workflows. AI has functioned in EP workflows in three major ways: streamline routine tasks, enhance data structuring, and offer superhuman risk stratification. A structured decision framework on readiness for adoption is shown. The major shift is continuous life cycle management because unlike static medical devices, AI models degrade over time. Ethical imperatives and implementation frameworks for clinicians are also fully discussed in the guideline. On April the 22nd, European Association of Preventive Cardiology released a consensus statement of optimal lifelong roadmap post-acute coronary syndrome. Key clinical highlights include individualized care based on high clinical risk phenotypes, specific goals on drug therapy, lifestyle, psychosocial, and sexual counseling, and long-term adherence in patient-centered care. Key advice not to do include: do not use older age, frailty, or advanced comorbidity as exclusion criteria for referral to cardiac rehabilitation. Do not perform final residual risk estimation before completing a cardiac rehabilitation program, and do not rely solely on self-reported adherence without objective monitoring tools. Move on to FDA news. On April the 23rd, the Centers of Medicare and Medicaid Services, or CMS, and the US FDA announced the regulatory alignment for predictable and immediate device, or rapid coverage pathway, a new pathway designed to expedite access to certain FDA-designated Class 2 and Class 3 breakthrough devices for people with Medicare. Through the rapid coverage pathway, CMS will now be a part of the early and frequent engagement between the FDA and device innovators. This pathway will link manufacturers to CMS experts early in development to understand what clinical outcomes are most relevant for Medicare beneficiaries. Last but not least, let's talk about how artificial intelligence has changed your practice. What should we know before adopting AI in the clinical setting? The HRS AI integration framework in EP workflow actually showed us a few considerations. I summarized those into 10 points. First, demand evidence, not hype. AI tools must have published validations, ideally prospective or randomized trials, not just developer claims. Ask for external validation in independent sites and populations. Second, use only regulator-approved tools for clinical decisions. For diagnostic, treatment, or risk stratification purpose, use only FDA-approved or equivalent software as a medical device. Off-label use introduces clinical and legal risks. Third, check the validation checklist. Vendors must disclose datasets, internal or external validation metrics like sensitivity, specificity, PPV and MPV, calibration, failure modes like false alarm rates, and prospective evaluation plans. Or ensure interoperability, not data silos. AI must integrate with your EHR and device system via open APIs. If data cannot flow bidirectionally, the tool will fragment workflows, not enhance them. 5. Never cede ultimate authority to AI. Human oversight is mandatory. Clinicians must make final decisions. AI outputs are advisory especially for closed-loop systems that could alter therapy, like device reprogramming. 6. Use implementation science frameworks. Apply REAIM, PRISM, or the 5 rights of clinical decision support. That is, right information, person, format, channel, and time, to avoid alert fatigue and workflow disruption. 7. Embed the microscopic magnification rule for AI. Not literal microscopy, but the principle. Strong AI outputs should be immediately obvious. Borderline findings require clinician reinterpretation. Weak signals are not actionable alone. 8. Monitor for performance drift. AI models degrade over time due to population shifts, new devices, or practice changes. Track key performance indicators like sensitivity, specificity, false alarm rates per patient month continuously. 9. Establish local governance, include clinicians, informaticists, data scientists, IT, and operational leaders. Define outcomes, for example, time to alert review, preventable events, and set thresholds for retraining, recalibration, or cessation. 10. Watch for bias and the digital divide. Ensure AI performs equitably across sex, race, age, socioeconomic status, and geography. Lack of diverse validation data risks perpetuating health disparities. So what's your suggestions? Anything you would like to share about your experience with AI, you're welcome to leave a comment. That's all for today. Enjoy your weekend and see you next week.